Assalamu alaikum wa rahmatullah. Good morning, young colleagues. My name is Khalid Osama and I am Associate Professor of Neurology. I'd like to welcome you all to the Neuropsychiatry module. Today I'll be talking about headache. Headache is one of the most commonly experienced complaints for any human being in the world, and it is estimated that about 1 person in every 3 complains of severe headache at some point of their life. Commonly, most people experience mild or isolated headaches and they do not seek medical advice. However, headache in general is one of the most common causes for outpatient clinic visits. So, from the name of headache, it is simply any pain that is felt in the head. It can be on one side or both sides. It can be local at a particular point or can be radiating from one point to another. Headache can be sharp pain or dull aching pain or throbbing pain, and it can be also sudden or gradual in onset, lasting for few minutes to few hours or even several days. The differential diagnosis of headache is one of the longest in medicine, as there is more than 400 causes of headache. This long differential diagnosis needed a strong diagnostic classification, especially in the absence of biological markers and decisive investigations. So this classification should be widely accepted to be utilized as a universal language promoting headache diagnosis and treatment. For this aim, the International Headache Society presented headache disorder classification known as the International Classification of Headache Disorders, or the ICHD, that is regularly updated, with the latest revision was done in 2018, and that was the 3rd revision. So the ICHD-3 is not intended to be memorized or learned by heart. However, this classification should be used as a reference guide from time to time for any physician dealing with headache disorders. Here we can see the main frame of the ICHD, or the classification of the International Headache Society, dividing the headaches into 3 main entities. The first one is the primary headaches, the second one is the secondary headaches, and finally painful cranial neuropathies and facial pain. The main pathophysiology regarding the headache in general is the processing and modulation of the pain input from the head and neck through the peripheral and central structures, and this can be through vascular etiology, inflammatory etiology, through tension or internal traction, or even epileptic etiology. Today, so investigations regarding a headache patient is not that common. However, we have some situations that investigations can be of real benefit. For example, routine laboratory tests can be indicated in patients with chronic illnesses or history of any underlying medical or neurological disease. EEG can be of value in migraine patients, or if the headache is associated with alteration of conscious level. Neuroimaging can be considered, especially in cases with any neurological examination abnormalities. So today we will focus on the primary headaches, and migraine is the most important disabling primary headache, with a prevalence up to 18%. Migraine has a very significant socio-economic and personal impact. It was ranked as the second cause of years living with disability in 2017 in the Global Burden of Disease announcement, and it was ranked the first cause within the age group between 15 and 50 years of age. The main major types of migraine are migraine without aura, migraine with aura, chronic migraine, and complicated migraine. Patients with migraine usually experience symptoms that occur before and after the attacks. These symptoms are known as prodromal and postdromal symptoms, and they can last for hours or even days before and after the migraine attack. These symptoms can include hyperactivity, depression, craving for food, repetitive yawning, fatigue, and things like this. The first main type of migraine is migraine without aura, and it has the following diagnostic criteria. As you can see, the patient need to have at least 5 attacks fulfilling the next points. Migraine with aura usually lasts for 4 to 72 hours if not treated. Headache is unilateral, pulsating with moderate to severe intensity, and aggravated by or causing avoidance of routine physical activity. Usually these symptoms are associated with nausea and vomiting, phonophobia and phonophobia. The other important type of migraine is the migraine with aura, and here the patient should have at least 2 attacks of migraine headaches with reversible aura symptoms that can be visual, sensory, motor, retinal symptoms, and have at least 3 of the next 6 characters. So at least 1 aura symptom spreading gradually over more than 5 minutes, 2 or more aura symptoms occurring in succession. Each individual symptom lasts from 5 to 60 minutes, and at least 1 aura of these symptoms is unilateral and positive, and the aura is accompanied or followed by headache within 60 minutes. The main pathophysiology of migraine headaches is the pre-symptomatic hyperexcitability that increases the brainstem response to triggers, and this causes the release of variable neurotransmitters including serotonin, norepinephrine, dopamine, glutamate, nitric oxide, CGRP, substance P, and these neurotransmitters activate the trigeminal nucleus, causing several symptoms as you can see on this diagram. For example, dilatation of meningeal blood vessels causes the throbbing feeling, the pulsating feeling. Activation of area postrema causes the nausea and vomiting. activation of the hypothalamus causes the hypersensitivity in the form of photophobia and phonophobia. The activation of the cortex and the thalamus causes the headache perception itself. So, to treat the acute attack of migraine, paracetamol is the first choice, especially in children. Non-steroidal anti-inflammatory drugs are also an alternative treatment for older patients, especially over 12 years of age. The next safe group that is effective in treating an acute attack of migraine are drugs named triptans. Triptans are very effective aborting migraine attacks in adults, being selective serotonin full agonist. We have also a group of drugs known as dihydroergotamines that are considered to be the most effective. However, they worsen the vomiting and nausea symptoms. They are also contraindicated with coronary artery disease, hypertension, kidney or liver dysfunctions. Novel oral CGRP receptor antagonists that rapidly penetrates the brain can quickly abort the acute attack. However, they have a high potential for drug-drug interactions and liver damage. As we always say, it's better to prevent than to treat. So to prevent the attacks of migraine headaches, we have two arms to do that. The first arm is to avoid migraine triggers. We have many known triggers that can precipitate migraine attacks, like drinks, especially alcohol, food, especially aged cheese, food with preservatives, processed food, skipping meals, also sleep changes like missing sleep or jet lag, medications like oral contraceptives, in addition to stress and sensory stimulation by bright light or loud sound or strong smells. These are all considered to be migraine triggers that should be avoided. The second arm is the medication arm that can be used as a preventive therapy of, and we have a first line and a second line for these preventive therapies. The first line with high efficacy are beta blockers like propranolol or metoprolol. We can also use tricyclic antidepressants like amitriptyline, and we can use anticonvulsants like topiramate and valproate. The second line is usually used after the failure of the first line, and here we have botulinum toxin injections that is used to inject muscles around the head, or the novel CGRP inhibitors, monoclonal antibodies, that are a new preventive therapy, providing a very effective preventive treatment. The second type of primary headaches is the tension type headache. And tension type headache is very, very common, with prevalence of up to 80% of general population, with a very significant socio-economical impact. It is characterized by being bilateral, pressing or tightening in character, with mild to moderate intensity, not aggravated by routine physical activity, with no nausea or vomiting. Sometimes tension type headache patients experience photophobia or phonophobia, yet not both of them. Over-the-counter pain relievers like paracetamol, non-steroidal anti-inflammatory drugs, and combinations between these two groups usually are the first line of treatment of this type of headache. In patients with both migraine and tension type headaches, triptans can be a very good choice in relieving the pain. And as we said, we have to try to prevent the headache before it begins, and we have some preventive therapies available for tension type headaches. First, we can use the tricyclic antidepressants like amitriptyline or protriptyline, and they are mostly used and vastly used for this type of headache. However, due to their anticholinergic effects, they have some side effects like constipation, drowsiness, and dry mouth. We have also the tetracyclic antidepressants like mirtazapine, and they have less common side effects compared to the tricyclic ones. We can also use anticonvulsants like topiramate. We can use muscle relaxants, and advise the patient to manage their stress levels and their postures, especially while sitting down for a long time, either during working or during driving. Another type of primary headaches is known as the cluster headache. And cluster headache occurs in series lasting for weeks or months, separated by periods of remission lasting for months or to even years. Cluster headache is characterized by being very severe unilateral pain lasting for 15 to 180 minutes and associated with ipsilateral autonomic symptoms as conjunctival injection, lacrimation, nasal congestion, and so on. These symptoms are usually associated with sense of restlessness and agitation. The most effective treatment of cluster headaches is inhalation of pure oxygen that can marvelously relieve the pain within only 15 minutes. Generally speaking, using oxygen as a treatment is considered super safe. However, carrying an oxygen cylinder and a regulator on the move makes it inconvenient and inaccessible at all times. Injectable and nasal spray triptans are also effective here. Intranasal local anesthetics like lidocaine may be also effective in treating the cluster headaches. And finally, again, using the dihydroergotamine injections is very effective. However, it carries a more risk for coronary artery disease, hypertension, kidney, and liver dysfunctions. So again, as we said, it's better to prevent than to treat. To prevent cluster headaches, calcium channel blockers as verapamil are often the first choice in the usage of or as a preventive therapy, with some side effects that may include lowering the blood pressure. Corticosteroids can also be used in prevention of cluster headaches. However, they cannot be used for prolonged period of time, as they can carry the risk of developing diabetes, hypertension, and cataracts. In the near future, we are expecting some potential preventive therapies like occipital nerve stimulation and deep nerve stimulation. Finally, on this slide, we can see the three types that we have been talking about head to head. As you can notice, migraine and tension type headaches are most common in females, while cluster headache is more common in males. Regarding the lateralization, cluster headaches are always unilateral, not as mistakenly known about migraine. No, the cluster headaches are the one type of headaches that is strictly unilateral. Migraine, on the other side, is only 60% of the cases are unilateral. The tension type is bilateral and diffuse. The pain character is also a very strong differentiation point. Migraine have a throbbing, pulsating pain. Tension type has a pressing and tightening pain around the head. The cluster headache is sharp and usually boring headache. Family history is very usual in migraine cases, and we can say that migraine tends to run in families, unlike the other two. Regarding the associated symptoms, the aura is very common with migraine, in addition to nausea, vomiting, phonophobia, photophobia, and exacerbation by exercise. On the other hand, autonomic symptoms are very common with the cluster headache. Hopefully you had a benefit from my presentation, and if you have any inquiries, please do not hesitate to contact us at the neurology department, either on the LMS or at the hospital during your clinical based learning sessions. Thank you so much for your attention.